So we're going to move into our first speaker. That's Philip Kregor from Nashville, and he is going to speak on the transverse and transverse posterior wall fractures, radiology approach, and treatment.
Greetings from Rosemary Beach, Florida. I'm from Nashville, and my charge today is to talk about the transverse and transverse posterior wall acetabular fractures. We're going to talk a little bit on the radiology. We talked last week on the approach, and then talk a little bit about the treatment. So my goals are really to have you understand the radiology of the transverse and transverse posterior wall acetabular fracture, understand the surgical tactics for reduction of the transverse fracture, and then have you remember what Eric Johnson from UCLA taught you last week about the posterior wall and combine that for the transverse posterior wall acetabular fracture. So the transverse fracture is an elementary fracture. It doesn't make it a simple fracture, but it was named elementary by Professor Letournel because of the purity of the fracture. So there's a typical transverse fracture. You see the one plane fracture. And then if that is combined with a posterior wall, of course, we have a transverse posterior wall. And then Dr. Riley will talk to us about the T-type fracture, where you have a vertical limb dissociating the anterior and posterior components of the ischiopubic segment. So the transverse fracture is a pure line fracture, and here is a radiographic depiction of it. In the CT scan, we oftentimes see the simple anterior to posterior transverse nature of the fracture, and in the bottom right there, a typical transverse or so-called transtectal transverse fracture. Because we really further subcategorize the transverse fracture into an infratectal or below the top of the cotyloid fossa, a juxtatectal or right at the top of the cotyloid fossa, and a transtectal or right through the articular roof of the acetabulum. Whenever you see a transverse fracture, I like to ask myself, am I sure it's just a transverse fracture? And what do I mean by that? Is there a posterior wall? And we oftentimes can miss that in the AP plane. So you want to look on the obturator oblique view. And then we also ask, is there a split between the two columns of the ischiopubic segment? And Dr. Riley will talk about that. So the transverse with posterior wall fracture is, of course, the transverse fracture with an accompanying posterior wall. As we evolve into the surgical treatment, when we think about the surgical approach options for the transverse, we have a standard Kocher-Langenbeck approach, which is used in the majority of cases. Occasionally, especially when combined with, number one, some pelvic ring pathology, or number two, some soft tissue concerns posteriorly, we may use an ilioinguinal approach. And occasionally we might utilize an extended iliofemoral approach, usually when the fracture is combined with some sacral or sacroiliac joint disruption. When we talk about the transverse with posterior wall, we know usually with the posterior wall, we're going to need to be posterior. And so even in the far majority of cases, we're going to utilize the standard Kocher-Langenbeck approach for the transverse with posterior wall. But occasionally, again, if there is an associated pelvic ring injury, we might utilize the ilioinguinal followed by the Kocher-Langenbeck for treatment of the posterior wall, and very rarely the extended iliofemoral approach. I think most of the faculty for the transverse or transverse with posterior wall in terms of the Kocher-Langenbeck would utilize the prone positioning as opposed to lateral positioning, although this is certainly debatable. It aids in reduction of the ischiopubic segment. It allows the surgeon to really palpate through the greater sciatic notch, the quadrilateral surface. It allows for clamp placement through the greater sciatic notch, and a very small aside, but it allows for an easier prep and drape. So this is the classic picture from the Jude table. And just to remember from last week, what we can actually direct visualize is in the purple there. And we can also palpate through the greater sciatic notch and actually place clamps through the greater sciatic notch in the red area there. How do we reduce the transverse fracture through the Kregor-Langenbeck? I think distal femoral traction can be very helpful. We can distract the hip joint and look inside the hip joint, particularly if we want to remove. We can utilize an ischial tuberosity Schanz pin in the ischial tuberosity. We can place angled jaw clamps through the greater sciatic notch or utilize a Weber clamp or Weber clamp. And we can also use screw-to-screw clamps or a small pelvic reduction clamp. So this is a schematic through Professor Letinel's book. Through the greater sciatic notch, we can palpate the transverse fracture. We can utilize screw-to-screw clamps. We can utilize an ischial tuberosity Schanz pin. This is another schematic. It happens to be the three entities that I utilize most commonly for the transverse fracture. There you see a Schanz pin in the ischial tuberosity. You see a screw-to-screw clamp, and you see a short angle jaw forcep through the greater sciatic notch and onto the anterior aspect of the transverse fracture. A sawbone model of the exact same setup. There you see utilizing it for a reduction and fixation of a transverse posterior wall. There's a close-up with a lag screw placed across the posterior aspect of the transverse fracture. So just a couple of case examples to kind of show you how this might be utilized in a transverse with posterior wall. This is an irreducible transverse with posterior wall fracture. You see the posterior wall there. This is in a 16-year-old all-state track star. There you see an attempt at reduction, which is not successful. And the reason is because the femoral head is in fact buttonholed through the short external rotators, as I will show you. This is the CT scan after an attempt at closed reduction. And this is the intraoperative photo. This is what we should be able to see through the Kregor-Langenbeck. And you see there the femoral head is buttonholed between the piriformis and the obturator internus and the accompanying gemelli, or the so-called conjoint tendon. If you ever want to know why the sciatic nerve is oftentimes bruised, here's a good example of that. You see also, as we talked about last week, that unmistakably the sciatic nerve is always on the posterior border of the quadratus. Here's the type of visualization in the same case after we release the external rotators. We can see, in fact, the transverse fracture. The posterior wall fracture has been reflected superiorly. The patient's head is to your right, the patient's feet is to your left, and there you see the transverse plane. This is the type of reduction, this is the type of visualization that is needed for an appropriate reduction, as you see here. Now, what makes the transverse fracture more complicated? This is a really important slide because I think it can save you literally hours in the operating room. If you have an ipsilateral SI joint injury, if you have a sacral fracture, either ipsilateral or contralateral, if you have anterior ring pathology or a symphysis disruption, and if you have the transtectal pattern. So here's an example of why we might utilize an ilioinguinal for a transverse fracture. This is a transverse fracture with accompanying pelvic ring pathology. This is the situation. And if you look at that, you obviously see a transverse family fracture. Of course, we're going to be asking, as we already talked about, is there a posterior wall? Is there a vertical limb? But if you then look to the posterior ring, you can see, even on this AP radiograph, a left sacroiliac joint disruption, and also you'll notice that the right iliac wing is externally rotated in this pretty good AP pelvis. And so we have a situation of a bilateral SI joint injury. So here's a reconstruction view of the CAT scan showing you that in the immediate period. There's a 3D rendering showing you that there is no posterior wall fracture in this case. And this is the patient in traction after she had an emergent splenectomy. And in this particular case, you can certainly debate this for a long time, but I made the operative choice in this patient who had a BMI of 45 and who had significant posterior road rash to do an open approach of both SI joints. Here you see on the left side the open approach with 2 plates and then an iliosacral screw for added stability. And then through an ilioinguinal approach, a reduction and fixation. This is challenging. The typical problem is a slight peripheral gapping of the transverse fracture posteriorly. There's the initial postoperative situation after a direct anterior approach to both SI joints and an anterior approach of the transverse fracture. You see a slight peripheral gapping, as I've talked about. There you see the reduction in the 2 Judet films. Unfortunately, this patient has gone back at 1 year. She's actually followed by another member of the faculty in another city, but she's lost a significant amount of weight, 55 pounds, is now running, and I think a reasonable result for the pretty complex injury. So the extended iliofemoral can be reserved in severely delayed cases greater than 2.5 to 3 weeks. The transtectal variant was historically ascertained by Professor Lertinel to need the extended iliofemoral, although I think that's rarely used for a simple transtectal transverse in today's world, and also a significant sacroiliac joint disruption on the same side as the transverse fracture. I won't belabor the anatomical details of a very complex approach, but this is a transtectal transverse in a 16-year-old male, and you see a very high involvement of the notch. This was done about 22 years ago by myself, and you see an appropriate reduction with the extended iliofemoral approach. So in closing, let's work through a case. This is a 21-year-old involved in a motor vehicle collision, and what I'd like to have you see is the struggle that I can have in reducing, hopefully, you see a relatively high involvement anteriorly. You see a very small posterior wall. Here is the iliac oblique with low posterior column involvement and a very subtle posterior wall fracture. This is the 3D reconstruction. You see that the anterior involvement is right below the anterior inferior iliac spine. There you see the 3D reconstruction. The posterior wall involvement. So the important questions, I think, is what's the radiographic diagnosis? Is there any complicating factor? Is there a pelvic ring injury? Is there a subtle SI joint injury? I'll tell you there are not. And then what are the surgical moves, tricks, and tools to reduce the transverse fracture? So let's just walk through the intraoperative photos. This is the initial situation. Here you see a typical setup where I'll utilize a Schanz pin in the ischiopubic segment and an attempt at reduction, which is not successful with a short angle jaw forceps. And then I'm elevating off the quadrilateral surface, showing here a finger on the anterior column just to show you that you can go all the way to the anterior column and palpate the transverse component of the fracture. Here's a mistake that you can make. That is utilizing a screw-to-screw clamp after the short angle jaw forceps is not successful, a screw-to-screw clamp, but please note, this is a mistake. There's a screw across the transverse fracture and you're not going to be able to reduce that. So then we can reorient that reorient that screw above the transverse fracture. And quite frankly, I was struggling with this fracture reduction. I have a posterior column plate across the low transverse fracture posteriorly. And when I got the appropriate reduction, I can put a screw in the proximal intact iliac segment, which you see there. And then I utilize an asymmetrical verbruge on this fracture to slowly get the appropriate reduction. I come with an anterior column screw, a true lag screw, 3-5-2-5 combination with the 2-5 there, a screw placement there, and then an additional lag screw, which is actually more perpendicular to the fracture for this transverse fracture, as you see there. And then we address the posterior wall, just like Eric Johnson told you last week. You see here an under-contoured plate with an appropriate reduction on the obturator oblique and the iliac oblique view. Don't always get a CT scan, but in this case, confirm appropriate reduction of the posterior wall in this 21-year-old male. So in conclusion, the majority of transverse and transverse posterior wall fractures can be addressed with a Coker-Langenbeck. We may occasionally utilize the anterior approach, especially with multiple pelvic ring injuries. Learn to maximize exposure, as we talked about last week. And really the tactics are going to be the short angle jaw forceps, a screw-to-screw clamp, and a Schanz pin in the ischial tuberosity. Thank you very much.